Welcome everyone to today's webinar. My name is Reagan Hart with Nevada Hospital Association. The purpose of this webinar is to go over the required hospital quality measures assigned to your hospital type for the Nevada Medicaid Provider Hospital Provider Fee Program. These measures are required to be reported on a yearly basis. The webinar is for the general acute hospitals without OB services. The measure for this type of hospital is the safe use of opioids, concurrent prescribing. As we continue our work with the hospital quality measures, this session is designed to ensure you have a clear understanding of the specific reporting requirements for this measure and to address any questions you may have. The Zoom meeting today is being recorded, and we will have it available on our Nevada Hospital Association YouTube channel as well as our website. Please note that updated templates were emailed out and also attached to the Outlook invite. The information that was changed on the template was only the instructions page with corrected emails and then how to submit your completed measure. Today we have with us Sharian and Gretchen from Mercer, and they are going to go over the quality measure that is assigned to your hospital type. With that, I will go ahead and turn it over.
Awesome. Thank you, Reagan. Like she stated, my name is Sherry Ann Thompson. I am a senior medical consultant with Mercer, and I am accompanied by my colleague, Gretchen. I'll let her introduce herself.
Hi, everyone. Thanks for joining us today. Gretchen Horton Dunbar, consultant with Mercer, here supporting the measures.
Awesome. So welcome to our session on safe use of opioids measure for 2026 program year. While many of you are probably familiar with the risk of concurrent prescribing, this webinar will provide a critical refresher for your experienced clinicians and serve as a perfect onboarding resource for your newer staff. But before we get started, can we please have everyone help us out with attendance by typing in your name, title, and facility into the chat. Name, title, facility, and then we'll grab that just so that we can follow up with you guys after the webinar with any materials that we may need to send out. All right, so just take a beat. Name, title, facility into the chat. And then Gretchen, if you can grab that for me once you see it slowing down. And then during the presentation, feel free to ask any questions, again, using the chat. And then we do have a frequently asked questions portion where we will go over any questions that you guys may have. You can either write it in the chat, like I stated, or you can come off of mute during that time and ask your question. All right. I will go ahead and get started. Gretchen, you can move on to the next slide for me. All right, so this measure is all about patient safety, specifically tracking high-risk combinations of opioids and benzodiazepines that can lead to respiratory depression. It's an inverse measure, so this means we are actually aiming for the lowest percentage possible, so lower is better. This demonstrates safer prescribing habits at discharge. Next slide. All right, so the stakes are incredibly high here because co-prescribing these drug classes makes the risk of a fatal overdose 10 times more likely. So by monitoring this data, we aren't just checking a box. We are using hospital data to identify systemic gaps and support Nevada's goal of reducing opioid misuse by 2027. Next slide. All right, so let's go over our population. In the denominator, we're going to have your eligible inpatient encounters. So these are folks that are inpatient, Medicaid hospitalization stay that is less than or equal to 120 days that end during the measurement period. They must be 18 years or older at the start of the encounter, and prescribed at least one opioid or benzodiazepine at discharge. And then in order to be in your numerator or the event, this is when we have a concurrent prescription of the following: 2 or more distinct opioids, or 1 or more opioid and one, I'm sorry, 1 or more opioid and 1 or more benzodiazepine. Okay, so that's our numerator and our denominator. Next slide. Do we have a question? All right, okay. All right, so understanding your exclusions. Exclusions are vital for protecting your facility's score when treating complex cases where concurrent prescribing is clinically necessary. So I've categorized 4 exclusion categories here, and keep in mind that CMS added 3 new exclusions. So that may be something new for even your seasoned staff. So please make sure that everyone knows about these new exclusions added in 2025 by CMS. All right, so our first type of exclusions will be clinical conditions. So these are your patients with current cancer-related pain or sickle cell disease. The care setting matters, so those receiving palliative care or in hospice. Addiction treatment, so patients receiving medication for opioid use disorder. And then lastly, discharge status, patients who left against medical advice or AMA. So these would be considered your exclusions from the denominator. Next slide. This flowchart maps out the ECQM logic. It starts with the discharge medication list and then runs through a screening for those critical exclusions we just discussed. So if there's no exclusions and the high risk combination is present, so you've taken out the exclusions and you still have the high risk combination, then that encounter will count against your safe prescribing rate. All right. So that would be a numerator hit. And remember, we don't want the numerator hit. We want lower. Lower is better. Next slide. Okay, so I've also carved out some focus areas for best practices for your data extraction. Again, that ARTS norm mapping, ensuring all opioids and benzodiazepine in your formulary are mapped to the correct codes to allow the system to identify distinct drug classes. Palliative documentation, so making sure that we're creating specific order sets or documentation templates that automatically trigger that exclusion flag when patients are in palliative care or under hospice. Pharmacy reconciliation, requiring the pharmacist to review all discharge orders for any patient with more than one controlled substance to flag potential numerator events. And then lastly, EHR hard stops, implementing clinical decision support alerts that fire when a provider attempts to sign a discharge order with both that opioid and benzodiazepine. Next slide. All right, so here are some common capture pitfalls. We want to make sure that we don't fall into the duplicate dose trap. That's when you have the same opioid ordered twice, or you think it's ordered twice, but it's really just 2 different strengths. This can incorrectly trigger a numerator hit. Making sure that we're using the proper code for medication assisted treatment. So any type of addiction treatment, remember that is an exclusion. So we want to make sure that that is properly coded. Missing secondary cancer code, again, another exclusion. Making sure that We are capturing those secondary cancer diagnoses on the problem list, which prevents the system from excluding a valid chronic pain patient. And then again, medication reconciliation lag. We want to make sure that we're removing any active ECQM opioids that should not be there by discharge. Next slide. All right, so here are some frequently asked questions from previous program years. Now is a great time to drop any questions you may have in the chat, and then we'll go over those after we complete these frequently asked questions. Or if you want, you can just come off of mute and ask your questions at this time. All right, so question number 1, can you
Can I
provide...
go ahead or just see if it's okay if we come tomorrow? I have...
Okay, just remember to stay on mute, you guys, if you don't have a question. Question number 1, can you provide more background information on drugs to be considered for this measure? The safe use of opioid measure identifies individuals with discharge medications of a new or continuing opioid or benzodiazepine as identified on the medication discharge list. The Nevada Prescription Monitoring Program is an available tool to access a patient's controlled substance prescription medication history. Question number 2, as a CAH, do I report on patients in distinct units, such as psych, long-term care, and swing beds? We only count acute patients. So for the safe use of opioid concurrent prescribing measure, the LTC and swing beds should be reported if billed as an inpatient hospitalization. And then lastly, does the cancer exclusion apply to patients in remission? No, it does not. The exclusion is specifically for active cancer-related pain that overlaps with the encounter. So a history of cancer without an active pain diagnosis code will not remove the patient from the denominator. All right, let me check the chat to see if there were any questions so far. Thank you everyone for putting in your name, title, and facility. I appreciate it. All right, I do not see any questions in the chat. Does anybody need to come off of mute and you can just ask your question verbally if you have one? All right, well, sounding like we don't.
Yeah, before we jump off, Ryan and Tracy, could you please throw your hospital affiliation and title into the chat for us? And
It's
then
done.
thank you.
You're welcome.
It. I think
Thank
we
you.
caught everyone.
Awesome, awesome. All right, next slide. All right, if you guys think of any questions later on down the road, feel free to reach out to us directly via email. If you have a state-directed payment question, you can reach out to Ann Jensen. If you have a question in regards to the reporting template, that would be my colleague Liza Altarino. And if you have any clinical support or best practice type questions, that would be myself. And again, you can just email us directly, or if you feel like you need a little bit more time, we are open for 30-minute one-on-one meetings. And so you could schedule one of those by requesting it via email. Next slide. All right, so just some key takeaways. Please remember that Lower is better, okay? So unlike most metrics, this is a decreasing percentage. Also, just remember to get those exclusions down packed. Things like sickle cell, palliative care, cancer pain, those are exclusions, and we want them out of your denominator so that it does not negatively impact your score. And so that will take a good collaborative effort with your nursing documenting team and your IT team to just making sure that that logic aligns. All right. And so like if you guys don't have any questions again at this time, I will just say thank you. I appreciate you allowing me to be able to talk about these measures with you, this measure with you, and I'll hand it back over to Reagan.
Thank you guys for the presentation. It was very helpful. Again, the webinar today was recorded and it will be available on our Nevada Hospital Association YouTube channel. Once it is posted, we will go ahead and send out the links to you guys. Thank you so much for joining us today.
Thank you.